Well, the rationale behind our clinical study relies on preclinical data that show that the combination of bendamustine and cytarabine, which are two of the most active drugs in the treatment of mantle cell lymphoma patients, are highly synergistic when combined in vitro on mantle cell lymphoma cell lines. And this synergy is higher when bendamustine is given before RRC, and this is partly due to the fact that RRCTP, which is the active anti-metabolite of cytarabine, is significantly increased by the administration of previous dose of bendamustine. Our patients were elderly patients with mantle cell lymphoma, which means older than 65 or 60 to 65 if ineligible to autologous transplant. All patients were revised by pathology revision and were mantle cell lymphomas, and with 6% and 8% of them being a blastoid and pleomorphic variant respectively. Overall, we treated 57 patients from 29 centers all over Italy. It was a multi-center phase 2 study, and the characteristics of them were as expected by a similar population of elderly patients with mantle cell lymphoma, so were predominantly males, elderly males with advanced stage disease, and curiously Ki-67 was the median Ki-67 was 20%. Well, the efficacy was quite striking, as we had observed previously in our previous JCO published trial in 2013 with the RBAC and the standard dose of 800 milligrams per square meter of cytarabine. With the reduction of this dose, we observed anyhow a striking activity with 93% of patients achieving a PET negative CR according to CHISM 2007 definition, and only one patient that had progressive disease among the 57 that were treated, and the PFS after 2 years, which is more or less the median time of observation so far, is in the range of 80%, and overall survival is, at 2 years is in the range of 90%. So toxicity was significantly reduced compared to our previous experience with the 800 dose, which means that while patients in the previous study, more than half of patients had to receive a platelet transfusion, this was reduced to a third of patients, so the thrombocytopenia, grade 3 or 4 thrombocytopenia was halved compared with our previous experience, which was one of the main requisite of the study. In terms of febrile neutropenia, it was largely acceptable. It was 5%, and even leukopenia, neutropenia was acceptable. It must be noted that all this hematological toxicity was transient, and usually the duration of 2 or 3 days, and not accompanied by any further hemorrhagic or infective severe complication. I think that with this study we have demonstrated that RBAC 500 is a feasible, effective regimen in this difficult to treat population, which are elderly patients with mantle cell lymphoma. Our study has demonstrated that more than 90% of patients can receive 4 or more regimens of RBAC 500. Our CR rate is probably the best ever reported in this population of patients. The duration of response is also very promising, but needs further validation, and the future follow-up will help us also in understanding if this curve will remain high as it is right now, or will lower down with some later relapse in the course of the disease.